So my topic, when she called, usually she calls and says that choose a topic. And then it's very easy that you choose a topic on which you have been speaking till now. So some topic which I've already delivered, which I've already prepared, something like that. But then I felt that when she gave me the choice, I'm working in this area at the moment, auto verification of reports. So I thought, why not take this up so that it refines my own understanding and refines the process also in the bargain for the lab. So I took up this topic, so auto verification in clinical laboratory requirements and challenges. So this is a part of the post-analytical phase, and if you all realize, post-analytical phase is a phase where we talk about it very less. Usually we concentrate on the pre-analytical and the analytical phase, and the post-analytical phase is like, the stepchild. So today we are going to speak about this final phase of the laboratory work in which the laboratory results are evaluated until they are released. So the evaluation or review will include comparison with reference intervals, the clinical setting, and the previous test results for that same patient. So the purpose of this step is to detect potential errors before test results are released by the laboratory. So you would, traditionally, we do it, the authorized signatory does this. May it be the senior technical person, the MD biochemist, pathologist, microbiologist, whoever is the authorized signatory and has the necessary qualification, training, experience, and continual professional development. So the competence. So what does this person do? This person employs the mental algorithms in his or her own head. What is the patient? What is the value am I looking at? Is it a critical result? Do the pre-analytics seem okay? So after all this mental math, that person will decide whether to release the report or not. Vis-a-vis, the auto verification is a process whereby predefined computer-based algorithms automatically perform actions on a defined subset of laboratory results without the need for manual intervention. So in some places, especially the ISO 151892022, the word which is used is automatic selection of reports. And other places, the CLSI uses the word auto verification. So allow me to use them interchangeably for today's purpose. So what will the auto verification engine really do? It will take the pre-analytical information, the analytical information, that is the sample information, instrument status, what are the test result values, and then it will decide whether it can auto verify a particular result or not, or then whether manual intervention is required. So when anyone is thinking of setting up an auto verification process in the lab, what are the things that you should consider? What are the capabilities that the laboratory should have, the organization should have, or you should evaluate? So first is obviously the equipment, because the equipments will have to be fully automated and there has to be a certain confidence level in the performance of the instrument. So that you should be very careful whether the Six Sigma performance is there, how well are they transmitting the values, are the instrument flags for the errors robust, because all those reports have to be caught back, isn't it? So you have to look at the capabilities of the equipment, then of the laboratory information system, because the laboratory information system has to do a lot of work here. So your LIS has to be capable of handling the auto verification process. Then the personnel and the staff have to develop the algorithms, because there's not going to be any ready-made algorithm which is applicable to your lab and my lab. So the lab has to have domain experts, have to have people who will think and develop these algorithms. The IT team, you have to also think whether you have an in-house IT team or your IT team is sitting at some other place, because then that coordination is required to get your algorithms in place. So once you decide that auto verification module has to be set up in your lab, what would be the process steps? So first is you identify the test. Which tests you have maximum load? Where do you have the maximum confidence in the performance? Accordingly, you can decide which tests you want to auto verify, because you can't start off with the entire number of tests that you are doing. Then the middleware design. So LIS configuration and the middleware design. Both of these will play an important role in how much you can take your auto verification process ahead. Then you have to design the flowcharts, develop the algorithms, calculation of the automatic release interval, and then last but not the least, validation. You have to do a lot of validation of the algorithms that you have put in, using all possible scenarios, that what if the instrument flags, what if there's hemolysis. So you have to take into consideration all these factors and then validate the auto verification process. So the AV algorithms are usually designed with data filters based on instrument errors and quality control flags, then the serum indices for hemolysis, icterus and lipemia, the critical values and result range limits, delta checks and consistency checks. What are consistency checks? Interdependent tests. So if your TSH is this, then your free T4 or T3 should be this. That kind of a thing. Both should match. So that is a consistency check. So just look at this particular mental map. So this is something which all of us do when we are releasing a report. We have a test result, then we automatically always see whether that person, that patient has come to us before. Then don't follow it exactly, but just think of the think of all the mental calculations that we do. So we see that if there's a delta check, are there more results which also have been done in your lab before? Or are all these and the change in today's value compatible with the available clinical data? If no, then we do tend to call up the physician, we check with the physician for the history, etc. Then depending upon what the clinician tells you, you will decide to either release the result or do some kind of recollection, repeat testing or some reflex testing. If it's a critical result, again you will communicate to the physician immediately. If at all, you have to also do a review of the controls, review sample aspect and volumes, review the crude data if required. So this is the entire process which is happening in your head, my head, when we are releasing a report. So all this has to be incorporated now into your auto verification algorithm. So example of a simple algorithm, this is a part of CLSI guideline. So say for example, measure the serum BUN and creatinine within dynamic range of the instruments. Then you check the ratio, then you check the delta check limit. Okay, I'll talk about this later. And then decide whether you can auto verify the results. If not, they will go for manual review. So this is a simple algorithm which can be built. A slightly more complex algorithm where you are measuring serum or plasma sodium, okay, then here you are bringing in the paraprotein part, because as you know, if there's paraproteinemia, you may get pseudo hyponatremia. So you have to check for that. You have to check the lipemic index, etc., etc. So you may have a very complex algorithm depending upon the parameters that you are going to auto verify. So any algorithm, again, if there's a QC check fail, if there's an instrument error flag, indices check, if it's a critical result, in all these situations it will hold for manual review and corrective actions. So these are some examples of the algorithms which you can build. So AV algorithm is developed using rule-based systems. In the rule-based approach, the test result is predominantly evaluated using the if-then type of logic. So, you know, these are just a nomenclature of the logics that can be used. So, if the TSH is this much, then the, or if the cholesterol is this much, then what happens, that kind of a thing. Now, after evaluation, results that fall outside of the defined acceptability criteria are set aside for manual review by the laboratory staff. Now, in addition, these systems may also perform operations such as reflex test request, retesting, and automated addition of comments also. You know, we know that we are required to put in interpretations on the reports about the condition of the sample, or again suggest some further testing. So, all these also can be put in by an AV algorithm. So, words of caution. Laboratories with limited experience in AV should begin with simple algorithms. Higher AV pass rates can be achieved by implementing more complex algorithms after acquiring experience. Rule types comprising AV algorithms can range from numerical verification intervals, simple numerical verification intervals, that is, all results between 10 to 20 have to be passed that way, or Boolean rule sets. So, there are various statistical and logical rule sets which can be applied. And as results are released in two steps, that is from the middleware and the LIS, the algorithm has to foresee all the actions in each of them and how each of these will behave. And the testing and validation process should include both the middleware and the LIS properly. So, coming to reference change value, an important concept. Harris and Yasaka introduced the term reference change values. When there's a change in a serial result in a patient. So, you've done a hemoglobin for a patient today and 3 months down the line. How much should be the difference if no clinical event has occurred in between? Obviously, if the patient has bled or has had a surgery or has been put on iron, then it's a different thing. But in a if there is no clinical event which has happened, then the change between the two will be dependent on what? It will be dependent on the analytical imprecision and the biological variation. So, reference change values provide an objective tool for assessment of the significance of differences in serial results in individuals. So, RCV can be used for delta checking and auto verification in addition to as tools for monitoring differences in serial results in an individual. So, there is this very daunting formula. I mean, I can't even read it, leave alone apply it, or leave alone put in figures into this and try to calculate this. So, looking at this itself, half of the enthusiasm of trying to calculate the RCVs for our lab values and actually applying them was, in my case also, it was lost, because I am not at all a mathematician or a statistician. So this is where CVA is the analytical coefficient, CVI is the coefficient of intra-individual biological variation, so on and so forth. But thankfully today the internet is like what? Encyclopedia. So you actually have calculators. So there is a BMJ interactive calculator. You choose a test, put in the analytical variation, the biological variation, the reference interval which you apply, decide whether you want it at 95% confidence level or 99% confidence level, and enter your lab results and see whether the minimum change required to conclude that two serial measurements are likely different is called the reference change value, and arrows to the left and right of your first result show the RCV for this test. So if you populate it, you will get the figures ready-made onto the internet. Now still there is a challenge, because this logic has to then be incorporated into your middleware or LIS also. So just having a thing on the internet and being able to do 2 or 3 values will not solve your purpose, but yes, at least this is there for your understanding. And gradually I hope or it will happen that the LIS people will pick this up. So this is just an example. So for albumin this is for a particular lab. So this is not universal because your basic CV percent will be different, no, in each lab. So say for this particular lab, there's an analytical CV, an intra-individual CV, and then they have given the RCVs, which you can use for the delta check. So a delta check should be used as an integral part of the LIS with automatic alerts, indicating when the result exceeds the predefined limits of the delta check. The difference from the previous result is calculated as a delta percent change and compared with RCV limits. So when you have two values, one done last week, one done this week, you have to calculate the delta difference and then compare it with the RCV for that analyte to decide whether it is acceptable or not. So there's just an example here. So I'm sorry for the units because this I have picked up. These are not the units in which you and I usually report, but fine. So there is this value, this is the delta difference, this is the delta percent change, then the analytical variability within subject biological variation, the formula has been applied and you get a 17%. So look at this, the delta percent change. So delta check limit. So the delta check limit is less than 17% or rather 17%. So conclusion, the result is outside the defined delta check limit, this thing. Okay, so your delta check limit had to be within 17%, whereas here the difference or the delta percent change is 88.1%. So this result cannot be included in your auto verification. So similarly, there's an example of serum glucose. Now, if you have built an auto verification algorithm, then there are 2 or 3 examples which show how you will look at the data that you get from your AV algorithms. What was your specific criteria? What was the analytical measurement range? Was it a critical value? What was the delta percent check? Again, the time interval is also important. You have one glucose value 2 years ago, one glucose value today, or one glucose value 2 weeks ago and one glucose value today. It's a different thing, isn't it? 2 years ago, the person may not be even having diabetes. Now the person has diabetes and is on treatment. So the clinical settings will change. And then whether or not the auto verification is whether it has passed the value or not. So in example, yes, it has passed the value. In 2 and 3, it has not passed the value. So after you build your auto verification module, after you have put your algorithms in place, then this is how you will do your testing, validation and monitoring on a day-to-day basis. So suppose you have 100 reports or 200 reports which are being auto verified, it is the duty of the lab to keep going back and checking whether this validation holds true or not. So our experience, Golwilkar Lab since 47 years is a lab in Pune, and obviously it started off with typewritten reports signed by hand with the transcription check through a readback with the technician. The technician says T3 this much, T4 this much, TSH this much, then the data entry operator, then the authorized signatory, everybody is having readbacks, and then you actually sign out a report with hand. So this is how all of us have traditionally, even I 28 years ago was doing the same thing. Now gradual shift to automation, LIS middleware, and thus IT becoming the backbone of lab workflow, this has changed. So now all of us have a much easier life in reviewing reports as well as signing them out. Now throughout all these years, we have done a lot of in-house developments. So as much as possible. So we have not relied on direct ready-made softwares coming in for anything. We have always believed in trying to develop them ourselves so that we get the required customization for our lab. What is applicable for our lab? So just as an example, suppose, these are our early examples or which most labs are following as a, say, PBS review criteria. So in a previous review criteria also, you will feed in certain sets of rules into your hematology analyzers, and then you will see which which patient will require a PBS review and who will not require a PBS review, right? So something like this, that this person has a hemoglobin of 15 and a neutrophil of 77 and a total WBC count of this. So what we started doing gradually was that this is transcribed onto our report directly. We could build this logic into the LIS that from here I get the normochromic, normocytic, mild poly, and like I said, an interpretative remark, everything. We could develop it such that this can happen automatically. So like I said, in fact, I'll just go back. Necessity is the mother of invention. As the numbers go up, you know, year by year, day by day, year by year, you realize that you are going to have to make these kind of innovations. And that is how we landed up making them. Because ours is a standalone lab, we do not give a CBC. And we do not give a printout directly from the instrument at all. So we have all the hemogram requests are always, there's always a PBS made and the PBS was being seen. But with the increasing numbers now, we could do some things like this, where the very standard patients, we could give the descriptive findings also through the LIS itself. This is another example where we could get the hypomicro, all these which the instrument has flagged, onto our interpretative comments. So these we have worked in where an algorithm will look at these and give the applicable remark. Similarly, in urine we could do this. If you can see, out of the 272 samples processed that day, 115 urine samples have been released by automatic selection, and the ones which are not released, we know what we have to look in them. So in this, there is a higher number of epithelial cells. Here there is acetone. So this filtration also became easy. So for that particular urine, we could only look at the acetone and then release the report. So then coming to the biochemistry and building of algorithms, we have done that. I have given just a few examples. So say for HbA1c, we have to also look at the variant area. So you have to remember that when you are building the algorithm, you have to factor that in. Then you have to, for say B12, vitamin D, TSH. Okay, for TSH, there is an omit pediatric because I don't want a neonatal TSH to slip through. So all this thinking has to be done and the algorithms have to be built. Various types of programs can be used. You can either use the completely independent program for this, or then you can use your own LIS after upgrades, or your middleware, or a combination of all these. So we use a combination of all these three things. So applications so far in my lab and in other labs also are in core clinical chemistry, urine analysis, hematology. Now I have seen reports where they have been able to apply this to coagulation testing, to other departments also. Now obviously a micro report or a histopath report which has a lot of interpretation will not be, cannot be subjected to an auto verification. But there are certain reports which are giving their experiences in various departments and disciplines. So what are the regulatory requirements? The ISO 1518922022 speaks about automated selection, review, release and reporting of results. So it says that these criteria are specified, approved, readily available and understood by personnel responsible for authorizing the release of results. The criteria validated and approved before use, regularly reviewed and verified after changes to the reporting system that can affect their proper functioning and place patient care at risk. So you may change the method, you may change the reference interval. So all that has to be immediately incorporated. Results selected by an automated reporting system for manual review should be identifiable, and as appropriate, date and time of selection and review as well as identity of the reviewer are retrievable. When necessary, rapid suspension of automated selection, review, release and reporting is applied in case there's some problem with the instrument suddenly. Okay, and then after that you cannot just keep releasing reports automatically. You may have to be more vigilant. So you have to suspend this and perhaps look at the next 200 reports vigilantly and then go back to the auto verification engine. CLSI has two documents. This was an older one, auto verification of clinical laboratory test results approved guideline, and now there's an auto 15, auto verification of medical laboratory results for specific disciplines. So here it is talking about what you do in hematology, what you do in clinical chemistry, etc. The requirements to be documented, there is the intensive validation that you do, revalidation anytime changes are made. All this should be readily available and understood by the laboratory staff. The results which are held for manual review should be identifiable for a retrospective review, and ability to suspend the AV system immediately when necessary. So what are the advantages? One is obviously the turnaround time is improved. The operational performance improves. That is the immediate verification of a result, repeat analysis, reflexive testing, addition of comments, or suggested manual steps, including manual review of the result. Some uncommon events may be picked up, like plasma albumin exceeding total protein, or a marked discrepancy between the icteric index and the total bilirubin. Or see, if you have a good algorithm, it will even pick up the paraprotein which you have reported 1 month ago when you are giving out the sodium today, because you have put in the delta check also in place. So which in fact a pathologist may not remember, or if it's a large lab, you may not access that data, but an auto verification engine will very diligently and automatically go back to the previous data. So by automatically performing actions on results that meet well-defined criteria, more time is made available for manual processing of those results that require special attention. Though we may not like to admit it, inertia, judgment errors, and lack of updated knowledge plague all of us, right? So auto verification ensures that every result consistently receives the very same review process, whether it's 9 o'clock in the morning, 9 o'clock in the night, junior pathologist on duty, senior most pathologist on duty. This process will remain consistent. Auto verification algorithms provide the opportunity to develop more sophisticated algorithms that incorporate more extensive data than would be possible for a laboratorian to perform in a consistent, timely and accurate manner. Ours is a walk-in lab, like I said. There are people who are coming to us for 20 years. So I might have a report of one person every month. I get that data, but you imagine whether I can go through it while authorizing his report for today. So if I have this, then automatically the entire historical data will be reviewed. So necessity, I had put in earlier that as our hemogram numbers increased, we had to do certain changes. Now when COVID hit, and then now when dengue and chikungunya are absolutely rampant in Pune, necessity is the mother of desperation is what I thought, an innovation. So we even started, why only clinical chemistry, why only hematology, then why only urine analysis? So we started thinking a little out of the box, and then these ones, these kind of results, which any which ways we have no clinical history, or that even the authorized signatory is going to think in a particular way. Okay, so we decided why not try out for these kind of results also, serology, immunoassays, and we are experimenting with this. We are at the moment trying to play, obviously with great caution we are going, so our pass rates are not very high, but I have somewhere started the thinking and process that as many results that can go with auto verification, why not? Because it spares time for more important work, other work. So it is not that, it is a tainted subject, because there is a misconception that auto verification is remote authorization. There is nobody in the lab. They are not looking into results. They are holidaying in Goa or conferencing in Goa. It is not like that. Auto verification can be equivalent to a manual review, or rather at times I showed you it can take into consideration more extensive data points than what a human being can do. So disadvantages, creating AV rules is a complex process, validating the AV process is time consuming, the burden of rule maintenance and testing, and heavy burden of maintaining duly trained and qualified personnel to use these systems, and no broadly scripted common sets of middleware rules. So all these are the disadvantages, challenges at the moment which we are trying to overcome. Another important thing, with whom will the medico-legal responsibility lie? Will it lie with the algorithm developer who might be an IT person, the domain expert who has given him all the inputs, the technical staff, the authorized signatory, who? Yeah, so at the moment the vicarious responsibility lies with every lab director, but this is still a question which may come up in the near future as a very pertinent question. The future improvement of AV using a Six Sigma approach and artificial intelligence in AV with a lot of, I read these names, not that they make much sense to me. There is Dr. Riju Matthews here who might later on put some light on these terms. But what I mean is there will be a lot coming up and auto verification pass rates can increase significantly. So take home message is, designing and implementing an AV system is a demanding task that requires input from several knowledge domains. Pass rates of 50 to 60% are readily achievable at the initial stages. Unfortunately, the literature is scarce in works detailing how to implement rules and algorithms for the automatic release of laboratory results, mainly in the national scenario. So thank you, and this is our team, and this has been a project which required a lot of teamwork. So I thank my entire AG Diagnostics team, and thank you for your patient hearing.